basically how we do that is we thread the needle into the scar, and then we retrograde inject the anesthetic, which then will obviously numb that up, and then you basically go back through the scar until it feels kind of like you're going through butter.
Do you do scar therapy?
Mm-hmm.
Can you talk a little bit about like kind of the basics there? I'm not really too familiar with those.
Yeah, so there's two ways that you can approach scar therapy. One way is the ultimate goal, obviously, with scar therapy, in my opinion, is to make the scar more supple, so that way it causes less disruption in the system. Okay, what I mean by that is if you have, for example, if you have scar tissue on the inside of your knee, there's two things that scar tissue can do. One is it can trap nerves or nerve endings in it that can cause a cycle of neurogenic inflammation. That obviously, if you've got a whole bunch of dumping of substance P, CGRP, those neuropeptides, then you're going to have pain over that scar. Okay, that's one aspect. The other aspect is if that scar tissue is sufficient and it is in the right orientation and it has the right texture to it, what it can do is it can actually stop fascial movement. And so you could end up having a tethering of fascia down here that ends up resulting in less fascial movement at the hip, which could end up resulting in altered mechanics at the hip, which could then lead to a functional impingement, which could then lead to hip pain. And so even though the scar is not painful, it can result in a change in how the myofascial system transmits forces and energy throughout the body and can result in pain elsewhere. Now the approach for both of those can be the same. I generally don't really alter how I treat the scar, whether we're actually dealing with local pain versus an alteration in the mechanics because of the scar. So from an injection standpoint, because there's obviously castor oil I use quite a bit with patients because that helps with scar tissue a lot, using a heating pad over it. You can just take like a quarter or even a spoon, kind of like a gua sha type approach, and you can do that to help kind of free up some of the bands inside of it. But from an injection standpoint, there's two main groups of solutions you can use. One is your traditional scar therapy solution, which is going to be, it's usually just like a lidocaine, marcaine solution that's going to numb up quickly and also decrease the pain, but that more so allows you to go in and mechanically fenestrate the scar to actually try to break it up from the inside, okay? And so basically how we do that is we thread the needle into the scar, and then we retrograde inject the anesthetic, which then will obviously numb that up, and then you basically go back through the scar until it feels kind of like you're going through butter. So you're really actually trying to break up some of that scar tissue. The other solution is in our orthobiologic realm. So that's you can use PRP. You can use platelet pooroplasma, but I prefer PRP. And you can use different products if you want to, or the autologous stem cells. So generally, I would prefer adipose over bone marrow. But the goal with that is still the same. I still do a mechanical fenestration with it. Generally, it's less aggressive than if they're fully numb, just because it's really, really painful. And when we're doing the anesthetic version, we're relying solely, because the actual anesthetic is not having any healing properties for the scar tissue, whereas if we use PRP, there's anti-fibrotic growth factors that are released from PRP that are going to help, and so we don't have to be as aggressive on the scar tissue. But we're still going through injecting, fenestrating, injecting more, and again, at the end of the day, what we're trying to do is make that scar more supple. The appearance may not change, because that has to do, the appearance of it more has to do with the epidermis and dermis. But from the inside, we can create better fascial sliding tissues and less entrapment of nerves, which can help with that local or that indirect type of pain.
Would you do it, let's say someone was like a keloid former, would that change your approach at all? If it was causing like an adhesion?
Yeah, sometimes I've only had a few patients that I've decided to do this with on keloids. Generally keloids, I'm not gonna do it. But I add a little bit of dexamethasone in with the PRP. So a little bit of steroid in with the PRP. And those patients, the reason I decided to do that was walking through their minor surgery history and things like that is when there was dexamethasone on board with whatever they were doing, they either didn't keloid or they keloided a lot less than normal. And so for me, that was indication that I could go ahead and not just make a massive keloid in the process. Yeah.
Along those lines, if you were treating a keloid, I imagine you'd be going injecting into the body of the keloid itself, or would you still go below it, like so?
Oh, I'd want to go above, below, within, around. Yeah, I really want to bathe the whole area.
And that's the fenestration process.
Yeah.
They're talking about. And I imagine it'd be like a retrograde kind of injection. So you go in and as you're withdrawing.
Generally, I do, just because it's a little bit easier because you've made a 25 gauge hole that at least allows some fluid out. Because especially when you're in a really, really dense scar, it's going to be really, really difficult to. And sometimes I've had to and this was more so when I'm doing the anesthetic version, is I'd have to kind of almost do like a field block around the scar first, because I would go in and I just could not push fluid into the scar. It was so dense. And so I would come out and kind of almost do like a field block, so that way I could go in and at least do some fenestration to make some holes and some paths that wasn't as painful as it would have been if I did do the field block. And then I can inject the fluid, and then that can start to just, because remember the fluid as well is going to help open up fascial planes and spaces between tissues. Yeah.
Could you use an adipose for that?
Yeah.
You kind of stay there in place and.
Yep. I like using adipose for scars when I have the ability.
What about using the chondrolytic and fibrolytic effects of low-dose steroids?
I haven't ever really gone down that path.
Yeah.
And have you seen much research on it?
I've seen a few case studies, but it's more for like fibrotic contractures, like Timmermans and stuff like that. And less for scar, but I was thinking, why wouldn't it be the same?
Right.
efficacy?
I think my personal hesitation with that has just always been, what am I doing to the tissues around it in trying to get that particular area of the scar to be more supple. I think that's just been always my personal hesitation with adding in, outside of the times that I've used it for patients who keloid. And again, that's such a low dose that I'm using. But I think that's probably why I haven't really explored it much, just because of that hesitation.
Yeah.
And I would think that if you did a head-to-head comparison of PRP versus a low-dose steroid, that your 6 and your 12-month outcomes are going to be better with PRP compared to steroid.
Is this something you'd have to do multiple times in succession, short period of time, or would you do them spaced out?
I do them spaced out, and I take a very similar approach as I do with my joint injections. And so we track how the patient's doing, how the scar feels, because I actually just had a scar tissue injection probably about 2 weeks ago now, and the girl has already started to notice changes in the appearance and the feel of the scars. And so we'll just keep tracking to see how that does and correlate that with her pain until she hits a plateau. And because if she hits a plateau and she's 95% better, then I don't see the need to do anything else. But if she plateaus at 50%, then we can go in and intervene. So I generally don't have a protocol for like, okay, we're gonna do 1 a week for 3 weeks or
Mhm.
anything like that. I like letting the body figure it out.
Right.
Yeah.
Switch gears to extraarticular prolo.
Yeah.
So in addition to the tendon attachment sites, do you also inject into like say the body of the tendon?
Generally not, unless I, if there is a known tear and I'm using image guidance, I'll inject into the actual tendon where the tear is. And again, I really strongly, I'll use Prolo for that if like, again, a situation like we are here, like we don't have the option to do PRP, I will do Prolo. But if I have between the two, that's one of the times where I really strongly think that PRP does so much better intratendinous than Prolo does, that I really strongly make that recommendation. And the reason for not wanting to go into the tendon is because I actually believe and have seen cases and had cases early on where you can make someone worse from doing that, especially if you start putting a large amount of volume into a tendon, because you're splitting a really dense structure and you're splitting it up, right? And yes, that fluid will get absorbed and it will come back down, but I've seen enough handful of cases where we've made patients worse with doing intratendinous injections where there isn't a defect to that can hold that fluid, right? If there's a tear in the Achilles tendon, I know that I can go into that tear and inject, and the the tissue is already disrupted. And so I don't have to worry about, oh, I'm going in and disrupting normal tissue. And so generally I'm staying away from it. That's why, I don't do a lot of biceps tendon injections unless there's a known tear. I don't do any bicep tendon or Achilles tendon injections, just palpation guided. It's always under guidance because I need to make sure it's in that tear so that way I'm not potentially causing more issues.
And when we are injecting the enthesis of the tendon attachments, is the idea to inject around the enthesis or add within the enthesis?
Yeah. Yeah, we want to really have an impact on those fibroblast-like cells that are closest to the bone, which is going to be in the enthesis, which is our tendon or ligament and periosteum interface. Yeah.
Can we talk about the duration of treatment activity in PRP and stem cell?
What do you mean by treatment activity?
Like the duration of which you can still have a healing response?
So, generally what I've seen in clinical practice is prolotherapy, our healing can, and I'll say this it'll probably be our, kind of 2 standard deviations around the mean. So our 95% of cases are generally going to be about 6 weeks or so with prolotherapy. It's possible, and we've had it, but it's pretty rare that we'll be 12 weeks out on a prolotherapy and someone will say, oh, I'm still getting better. Usually they've plateaued by that point. So about 6 weeks for Prolo. PRP, generally upwards of about 3 months. I've had a few cases, and I was actually one of these cases where healing actually didn't start until like the 3-month mark with PRP, which was super, super strange. And then it occurred after. And both cases are, which one was mine and one was another case. Both cases were there wasn't anything else that was introduced that would just flip this healing switch. And so I'm still thinking it was the PRP, but I've had that on those 2 occasions. But again, 95% of patients are going to be generally done their healing by about 3 months. So that's usually why with PRP, I don't schedule a follow-up until 3 months, because generally I want them to go through that, at least that whole healing process before they come back. Because in a cash-based model, your patients might get upset that they just spent a whole bunch of money just to tell you that, they're still healing and we're going to continue for not do anything and just see you in 6 weeks. And now, as the practice grows, I know that I'll eventually have a nurse or a resident or someone just pick up the phone and make a brief 5-minute phone call. Hey, are you still healing? Great. The doctor will see you in 3 months. Or, oh, you've plateaued. Okay, let's get you in for your follow-up earlier than the 3 months. So from a practice management standpoint, there's different ways you can handle that. And then stem cells, honestly, it can be upwards of a year. I've seen cases where patients are coming back in at 9 and 10 months and they're still getting better. So, and I think that is, I think that's twofold. One, because the strength of the therapy, and so the amount of, it's not like Prolo, we're getting the same amount of healing the stem cells and it's condensed to 6 weeks. It's, we're getting here with Prolo at 6 weeks and we're getting here with stem cells at a year, but obviously there's a big time gap in between, right? That's one thing. And two, I think when we do a stem cell treatment, we're initiating such a deep mechanism for healing that is, I think, so much more profound than what we're getting with Prolo and PRP, because we're now encouraging cell-to-cell communication in a way that we aren't with Prolo and PRP because they're acellular. That I think that you're just seeing deeper level changes that just take longer for them to work, but you end up getting a much better result out of it.
An initiation of healing can happen at any point, like the start, a week in, 2 weeks in, pretty much for all the treatments.
Yeah.
In regards to IT band pathology, I haven't heard too much of. Oftentimes, like when we're assessing maybe lateral leg pain, we're thinking dermatomes or myotomes. When do we start thinking, no, this is more of a IT band pathology, and how do we assess for that?
So, generally, IT band pathology is going to present as lateral knee pain, right? Because where that IT band ends up inserting is on Gertie's tubercle, which is lateral aspect of the proximal tibia, right? And so runners will get that frequently, where they've got kind of this like nagging lateral knee pain that that they get when they're exercising or running and that kind of stuff. Cyclists get that too.
Yeah, if they have an improper setup on their bike.
Yeah.
Common.
Or form.
If their seat's too low and they don't know it.
Yeah. Generally, it doesn't present. Now, tenderness to palpation over lateral aspect, we get some of that hyperalgesia and allodynia, and I think that's because we are trapping a lot of the lateral femoral cutaneous nerves that are traveling in that area, and why it hurts like hell to foam roll it when there is some pathology. But in terms of like a patient coming in, generally won't say, I have pain here, it's I have pain here. With that though, the number one thing that you need to do is you need to loosen the muscles that are feeding into that system. Because the way the IT band is basically just a thick fascial band that is the connection of fascia from a few different muscles that then transmits across the joints. Basically a way to have the hip help to control the knee joint, right? So you've got the TFL and you've got glutes are like the two biggest things that are going to feed in to this IT band that then basically becomes a tendon and attaches on Gertie's tubercle. And so actually loosening TFL and the glutes are probably the biggest thing, because when you have this lateral knee pain, it's because there's an excessive amount of force being pulled upwards at this spot. And so you're compressing the joint a little bit, but you're also getting some micro tearing at the insertion from the excessive force. And so a lot of people will come in, they'll roll their foam rollers, which will temporarily help. And I don't believe you're making a change in the actual IT band when you do that. Tension in the IT band. And so when you loosen those, the IT band will temporarily feel better, but if you're not addressing the root cause, which is generally up at the hip, then that tightness is just going to come back, and they're just going to need to keep foam rolling every day. And so coming in and doing some body work, you know, either with, I love the lacrosse ball or the softball, anything like that, and the TFL and the glutes, it resolves this really, really quickly.
And it's more common to see pain at the IT band attachment than at the TFL or glute attachments, maybe like behind the iliac crest.
Yeah, oftentimes it's actually right above the knee joints or along the lateral femoral condyle is where they used to think of it as a friction syndrome. It's not necessarily a friction syndrome, but if it's really tight because these muscles are really tight, the IT band starts to adhere to the lateral aspect of the quad, and then it gets trapped here, and then you start getting pain here. And so it's less often the enthesis that actually is in pain, it's just this area right here, the lateral femoral condyle. So when you roll, you're actually, like Dr. Timmermans was saying, you're moving the muscle, you're trying to actually release the muscle from the IT band overlying it. So a lot of the foam rolling they're kind of moving towards now is actually cross. So instead of going straight up and down the leg like this, you're actually going to try to move the quad away from the IT band and then the hamstring away from the IT band.
For less friction. Makes sense.
And then, but if you don't, like with cyclists, if they don't change their bike fit, it'll just always be.
Yeah, the root cause in them is
they have to take time off to do certain things. Like you can train, it just will never go away.
Yeah.
So fix your bike seat,
Remove the
take some time, do some PT, it'll go away, and then it's just a matter like you don't need to do a lot of stuff, but you need to address it.
Yeah.
For Piriformis Syndrome,
Yeah.
is it still for prevention and then after treating maybe the acute symptoms like compression on the sciatic nerve, is stretching still the best way and specifically like this good old stretch?
So I think at some level we need to decrease that tension in piriformis. There are many different ways you can accomplish that, and stretching and the figure 4 stretching or whatever they call it can be beneficial. But I think there's faster ways that you can incorporate some form of change. And I've personally found with myself and patients that the quickest way to create change is actually doing, it's a type of active release. So it's not an active release in the sense of a therapist is coming in and releasing with active range of motion. It's not like that. Or even you releasing with an active range of motion. It's actually more training your brain to let go. And so I love you can use foam rollers for this. I love using lacrosse balls and softballs or whatever other gadget you have. But if you apply pressure to a muscle and you cause a instinct in that muscle to contract, and you override that and you cause a relaxation in that muscle by actually using your mind. Like you think about, okay, I'm going to relax this muscle, I'm going to relax into that pain. Excuse me. That's where you start to actually change the neuromuscular connection. You're involving the nervous system in releasing this muscle. Because a part of what you have to do is you also have to train the muscle that's safe, right? Because generally what happens is because our body, like, it uses the muscles to understand where we are in space, right? And especially like the Golgi tendon organs and things like that. And so our body is always trying to protect us by not just falling apart. And so it uses tonicity to kind of gauge that. And so one of the things that I think is important in patients who have chronically tight muscles, aside from addressing the nerve side of the equation, right, if there's neurogenic inflammation, is involving the nervous system to teach them that your joint is safe or your body is safe if you relax. And one of the ways you can do that is by, let's say for Piriformis Syndrome, sitting on a softball when it is all painful as hell and your body and piriformis and glutes go whoop, and then you override that mentally by saying, nope, I'm good, I'm safe, and you relax the glutes into that softball. That's when you can start making real quick changes. Yeah.
I love that.
So yeah, this works, but I think there's a better, more efficient way.
Awesome.
It's the same concept with ice baths and Wim Hof.
Yeah.
Relaxing in the stressor. Or
Yeah.
staying comfortable.
Yep.
Retraining.
Yeah, it's
It's a
Baseline
parasympathetic response.
Yeah, it's retraining your nervous system that you're safe. Yeah. And the physical therapy world is really, really waking up to this, and I'm really excited to see where they go with it. But on basically developing programs for people to, instead of working through their pain, is actually creating an environment where they can do exercises that are either modified or less weight, or like, so if they're in a pool or something like that, where they are pain-free, even though if they did this movement with weight or their own body weight, it would be painful, because what that's doing is that's teaching the brain that this movement is safe. Going into a flexion position is safe, and you can slowly actually train the brain to understand that that's safe, and just that alone, without doing any other type of injections or treatments, can actually retrain the brain to not have that painful stimulus from the low back. And so I'm excited to see where that goes over the next 5-10 years.